All right, guys, that was our break. Thank you so much to everyone who decided to donate. It's really cool to see the money come in. Um, right now, I'm going to give the word to Dr. Ansari. He's going to give a presentation on the Afghanistan case.
Thank you very much. Thank you, the organizers of the symposium. Thanks for inviting me. Good afternoon, everyone. My name is Nasratullah Ansari. I'm from Afghanistan, and I migrated with my family to the Netherlands in December 2016. So although my migration situation was different from the rest of migrants, still we faced some challenges, many challenges, including the asylum seeking procedures. I'm a medical doctor. I'm a gynecologist, obstetrician and gynecologist. I practiced obstetrics and gynecology in a hospital in Afghanistan for many years, and I was teaching at university in the northern part of Afghanistan. So when I was working at that hospital, I'm telling you the story of the maternal and newborn health care in that hospital briefly. So the main challenge was the high case fatality rate in that hospital. It was very, very high. And there were two main problems. First, many women came to the hospital at the latest stage of their complications. And second, the quality of care, of course. So the main, when the women came to the hospital, they were facing with challenges at the hospital at the entrance, from the entrance up to the wards, everywhere, and they were suffering from hemorrhage or eclampsia, preeclampsia, you can say a hypertensive disorder during pregnancy. So and infection, sepsis, abortion. So these were the main causes of maternal deaths in those hospitals. So I was practicing there and I was thinking how we can find the root cause of why women are coming to the hospital at this stage. So I received that, it was around 2005, and I received an offer from the JPIGO, an organization affiliated with Johns Hopkins University. And they asked me if I was interested to join them in a research on postpartum hemorrhage. So I happily joined them, and the aim of that research was to find a solution for prevention of postpartum hemorrhage, and to see if postpartum hemorrhage can be prevented at the community level, at household level, to reduce maternal deaths in the community. So I joined them, and I enjoyed working with them, and certainly I thought that I was moving from healthcare, or maybe you can say from medicine to public health field. So after conducting several researches and designing many health interventions, and supported the government of Afghanistan to design and also to develop health policies in order to improve maternal and newborn health situation in the country, both at the community level and also at the health facility level. Later in 2012, I moved to the Netherlands, and I studied public health at Royal Tropical Institute, KET, in Amsterdam. And when I went back, I rejoined JPIGO, the Johns Hopkins University. And meantime, in 2014, I started a PhD program at FU University. So my promoters were Professor Jale Stengelenberg and Professor Jos Rosmalen. So together we started the program and conducted several researches. So in the meantime, I was leading the country on behalf of Japango and implementing health interventions to improve maternal and newborn health, including sexual and reproductive health rights, family planning, post-abortion care, health during pregnancy, childbirth, and postpartum, newborn health. So there were many interventions around the country. In the meantime, supporting the government of Afghanistan for their policy developments. Later, in 2016, 2015, 2016, I received several threats, life threats from anti-government elements in the country. And because I was supporting sexual reproductive health rights and family planning, and abortion, so this kind of stuff, and supporting women's rights, working with Americans. So I decided, based on my advice based on the advice that I received from my colleagues, and looking at my situation, so it was desperate. So I had to leave. I had to flee the country, and I moved to the Netherlands. Later, we immediately settled in Almere in 2017, December 2017. Sorry, December 2016. And I started focusing on my PhD program. In the meantime, I was providing support to Afghanistan country office from distance. So, of course, I felt relief because I was safe, my family was safe. In the meantime, gradually I was suffering from depression and anxiety. So it was due to post-traumatic stress disorder. So I tried to seek help. So it was a challenge because seeking help from household was a little bit of a challenge because of referring to another facility, delays, making appointments. So it was a little bit frustrating. So anyways, so as a medical doctor, I knew what to do. I knew how to cope with this challenge. So I knew the coping mechanisms. So I practiced them for months and months. And I fought against it. And I succeeded and I won. It was a challenge, but I succeeded. So I can imagine how immigrants can suffer from these kind of mental health problems and how they're facing. Because I was lucky, I was among the lucky ones, because I knew Netherlands. I had contacts, I had connections with Dutch people, and I was engaged with the university, so I had access to healthcare. But I can imagine the other immigrants were in the Kwa or in the camps and feeling desperate and exhausted. So it's a very, very difficult phenomenon, particularly in immigration. It's not an easy process. It is really, really tough and exhausting. So as an immigrant, a medical doctor, and public health expert, so it is my pleasure to talk about this challenge, about the immigration and health with you today. So my talk is more about Afghanistan case. So I'm talking more about Afghanistan. It is a country located in South Asia and neighboring Pakistan, Iran, China, Turkmenistan, Uzbekistan, and Tajikistan. So it's a low-income country, very low-income country. So you can see the GDP is 572 per capita. and the population is about 34 million. So if we talk about Afghanistan, it's about war, politically. And it has been for 40 years. It destroyed the social and political and economic structure. 2 million people lost their lives in the last 40 years, more than 2 million, and 1.5 million disabled, and 5 million migrated. So the conflict continued for many years, has been continued for many years. War against Soviet Union in 70s and 80s, civil war between Mujahideen in 90s, another civil war between Mujahideen and Taliban. Now it's between Taliban and the government. It started in 2001 and it continues. So due to the war and devastation of social structure, majority of Afghans, 5 million Afghans migrated to many countries, particularly majority of them migrated to Iran and Pakistan. And few of them made journey to Europe or America or any other countries in the world. So the current situation, the work, of course, the work continues. Just last year, about 10,000 civilians, including men, women, children, either killed or injured. Among them, about 1,200 women were killed or injured. So 44% of women were affected by ground engagement between the Taliban and the government or coalition forces. And even from air strikes by the government or by coalition forces. So it is, I mean, all the civilians are affected, children, women, and men. So the most critical and devastating is the loss of lives and casualties. And beside that, gender-based violence is increased. And a recent study, a recent survey showed that about 70% of women suffered from either physical or verbal violence in the society or in the household. So it is a very rough number. It is very high number, I can say. The rate is very, very high. So it is because of the war. One of the reasons is the war. So despite all bad news, in 2001, when the new government established, investment in public health began. The number of health facilities increased from 500 in the entire country to 3,500. And access to healthcare services increased tremendously. I can give you an example of, for example, the skilled birth attendance rate was 9% in 2001. It increased to 50% by now. And maternal mortality and child mortality decreased tremendously. But again, war continues. Health facilities are targeted. Hospitals are targeted. You can say earlier this year, a maternity hospital in the heart of Kabul, the capital of the country, was attacked by Taliban. And many women, pregnant women, women during childbirth, and newborns were killed. it's one example, and there are many examples in the country. So facilities are destroyed, or you can say when a facility is destroyed, they can say it's a collateral damage. So it is unacceptable. And the access to healthcare is decreased because of restriction of movement due to insecurity. In the meantime, as compared to 2001 and 2010, at the moment, the economy is down. And it's very difficult for the government to find funds to support to run the health system. So it is a big challenge at the moment. So the most vulnerable people are women and children. So they are the women. The total fertility rate in Afghanistan is very high. It is 5.3. Maternal mortality is still high, although it was in 2001 it was 1,600. Now it is around 1,200, but the recent data shows around 800. But it's still high. Very high, and neonatal mortality rate is 22 per 1,000 live births, and as compared to the Netherlands is 3.6, so it's not comparable. So most women die during pregnancy, childbirth, or postpartum due to postpartum hemorrhage, hypertensive disorder during pregnancy, like eclampsia, preeclampsia, obstetric labor. Sorry, it's not obstructed labor. Sorry, it is a misspelled. Sepsis and abortion. So these are the main causes of maternal deaths. So these are the main causes. So when we talk about migration, they should be considered. For example, postpartum hemorrhage, because most of women, as compared to European women, most women in Afghanistan are anemic, so it is a predisposing factor for hemorrhage. So the common health problems among Afghan women and children are infectious disease like tuberculosis, malaria, leishmaniasis, and typhoid fever, and non-communicable disease like cardiovascular disease, chronic respiratory disease, diabetes, cancer, and mental health. Mental health is a major problem among women, particularly among women in the entire country. So most children die because of respiratory infection and diarrheal disease. And congenital disease is also a common problem at the moment. So when we talk about migration, there are different challenges. We need to understand the migration first before we talk about the health. So migrants have different health problems in different locations. So before we talk about health, we need to understand them first. So at the moment, despite many organizations and institutions, including WHO, European Union, and in high-income countries, are working in the migration and the health of migrants, but it's still, there are many publications prove that it is not clear. It's not fully understood, and there are poor communication between healthcare providers and migrants, and the host country's responsiveness is poor, still is poor. So it is a challenge. So as I said, migrants have different problems in different locations. If we categorize the locations that can be linked to the health problems, we can divide in three: the home country problems, during journey, and also the host country problems. Of course, it's all three of them are interlinked. And at home, the impact of war and political instability has a huge, migrants are affected hugely by that. And during journey, they're facing with accidental injuries, hypothermia, for women, gynecological and obstetric complications, and many other problems. And of course, infectious diseases is common, and mental health, mental illness, mental health problems. In the host country, when the migrants have predisposing factor for mental health, when they come to the host country, it is aggravated by language difficulties, cultural and religious issues, racism, and unemployment. So it becomes aggravated, exacerbated. So who are the most vulnerable people? The most vulnerable people are women and children. And because they are at high risk of sexual abuse for women, and pregnancy, and they poor access to oral contraceptions, poor access to antenatal care and during childbirth and postnatal care. And for children, of course, they have respiratory, as they come from their countries, for example, when they come from Afghanistan, they have already have challenges, and challenges like malnutrition and other problems like respiratory or gastrointestinal infections. And it can be exacerbated by migration. And during the journey, for example, they can face with dermatological conditions like scabies. And the newborns are facing with low birth weight or prenatal and neonatal mortality. WHO, in collaboration with many institutions and organizations, has developed several guideline strategies and reports about migration and health. I really like the title of 2018 WHO's report. It's mentioned that no public health without refugee and migration health. So this is interesting because it promotes the integration of host countries' health system with the migration health. So it's crucial to integrate migration health into the health system and policies and strategies and plans of the host country. And now for us, for example, in this symposium, there are many students. They should understand that the integration of migration and health is crucial with the medical education, because future doctors should understand the complexity of migration and health. Not only healthcare, not only necessarily healthcare, but health as a whole. And they can be educated on not only education for the medical education, but also as a whole system. The person-centered and compassion and comprehensive integration of health care is important, is crucial. The other important issue is the strengthening the national data collection system. The routine data collection and also the researchers are crucial. So we need data about migration and health to understand better the problems of migrants, health problems of migrants. I'm going to end my talk with reciting Sadi's poem. Human beings are members of a whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasily will remain. If you have no sympathy for human pain, the name of human you cannot retain. Thank you very much. If you have any questions, if time remains, we have 5 minutes.
Thank you so much, Dr. That was a really nice presentation. We wanted to ask everyone to keep their presentation, their questions, because right now we're going to have a panel discussion. And it might be nice if you guys can both answer questions that can come up. So right now I give the word to Simone Goosen and Dr. Ansari. Oh, excuse me, I'm confused. I mean, I give the word to Dr. Goosen. She's going to be giving a presentation. And afterwards, Dr. Ansari and Simone Goosen are going to do a panel discussion. Anyone can ask their questions then.
Good afternoon, all of you. Inke, do you see my screen now?
I don't see your screen yet. Are you sharing your presentation?
Yep. Okay, it's coming, I
yes,
think.
I
Okay.
see it.
Yep. Thank you very much. And thank you very much for inviting me to contribute to your very important and interesting symposium. You've heard so many impressive stories already, and I think that what I can add maybe is the situation in the Netherlands, refugees in the Netherlands, and I've worked in this field as from 2001 at the Netherlands Association of Community Health Services as an epidemiologist and policy advisor. And I did my PhD on epidemiological studies into the health of asylum seekers and refugees at Amsterdam Medical Center. And next slide. Currently, I'm working as a lobbyist and campaign leader, and also some advisory work with respect to epidemiological studies and other studies into the health of refugees. But I work currently at Johannes Wier Foundation for Human Rights in Healthcare. And the right to health is about ensuring that everyone, everywhere, can access affordable quality healthcare. And I think that Dr. Ansari already, in his own private story, already told you how difficult it was to access healthcare when he was having mental health problems in the Netherlands. And well, that's something which is, I think, a main issue. How can people access healthcare? And language is an important barrier in that sense. Steven van der Vijver already addressed it for the camps in other parts of the world. And in fact, it's the same issue here. And somehow several issues with respect to health of refugees are politicized. I mean, what happened in the Netherlands is that in 2012, the then Minister of Health decided that medical interpreters were not funded anymore. The funding was stopped. And she said that, in fact, people who don't speak Dutch sufficiently should themselves pay for or bring friends, family members, whoever, to translate in medical practice. And as from 2015, when there were the large numbers of refugees coming from Syria and Eritrea, I started working on this field together with lawyers, for example, and many colleagues in all kinds of national organizations. And so that's my work as from 1.5 years ago, as a volunteer, trying to get the policy changed with respect to interpreters in healthcare. And well, I can say that we've already gained a big step. The situation now is such that policy-wise, interpreters should be used and when needed to provide good care, of course. And also, the ministry has said that funding should be arranged. That doesn't mean that automatically it's arranged for everywhere, but we've made a big step. I'll get back to this topic a bit later on. And in fact, I wanted to do a poll. Is it ready, Nienke? Can you help me with the poll?
Yes, if you give me the question, I'll put it down.
Who are entitled to full access to healthcare in the Netherlands? Just a question to find out for us how many of you have an ID. And I say who live in asylum seeker centers, refugees with a residence permit, quoting refugees who have been invited from the camps. Most of them come straight to the Netherlands, so they don't need to flee through Southern Europe. They are invited to come here, otherwise they would not be able to. Undocumented migrants, people who don't have a residence permit. And then next answer, 2 and 3, or all of the above. Well, still some answers coming in. And in fact, most of you say either groups 2 and 3, the refugees with a residence permit and the quantum refugees, all of the above mentioned groups is mentioned a lot as well. And in fact, well, the question isn't that easy. That's a strange answer maybe, but officially everyone should have full access to healthcare. So all of the above mentioned groups. In practice, it may be very different. Persons in asylum seeker centers, they have near full access. It's only conditions that cannot be treated quick enough. They wouldn't be advised or given that kind of care. Refugees with a residence permit and quotum refugees, they have full access. So 2 and 3 is good as well. And for the persons with non-legal status in the Netherlands, so the undocumented migrants, there is in fact reports that state that they also should get full access, but in practice it's very difficult. I'll tell you a bit more about that later. Thank you very much. It's not that easy, but I think it's why I asked this question to you, to think about it and realize that if you get persons in these groups in your practice, whether you're working as a family practitioner, a public health doctor, or in clinical care, there is differences, and in some cases you really need to know and to find out, because you may need to act differently. But let us go to a case that was told to me by a family practitioner who, not as a family practitioner, but as a carer, in fact, helped a young Uyghur man of 20 years old, approximately. For privacy reasons, changed his name a bit. There was no contact for him. He arrived in the Netherlands a few years ago. No contact with his family in China, because it would be very dangerous for them. Highly traumatized, as told by the family practitioner. In the Netherlands, he was extremely bored in the AZC, waiting for his legal procedure. Nothing to do. I mean, he traveled through Turkey and Dubai. In both countries, he'd been able to work, but in the Netherlands, he was just waiting. And after some time, he got, well, serious complaints, and it was found out that he had lymphocytic leukemia. What happened is that in the medical encounters with the family practitioner, sometimes even joining him, which was a Dutch family practitioner not able to speak his languages, the medical encounters took place without an interpreter. And then on top of that, there were cultural differences. So the situation was very difficult. And when he was told that, well, it might be cancer or maybe not, and it was very uncertain what it was, he really lost trust in healthcare, and he refused the cancer treatment. And he died last year. family practitioner who really cared for him as a family member, she's still shocked, in fact, with what happened and also how the boy was treated in the medical services. And on the other hand, she tells a different story as well, because she, as a practitioner herself, I mean, she's in her early 40s now, so she's got a lot of experience as well. She realizes how difficult it is to give cultural competent care, and also that she hasn't always used and worked with an interpreter. So that as a case study to share with you. If we go to the different groups, well, we have people in asylum seekers, different groups, because there is mainly people waiting for their asylum request, but there's also a lot of people, approximately 1 out of 4, who already have a residence permit but are still waiting for a house in the municipality. Currently, there's 27,000 persons living in the centers, the 67 asylum seeker centers spread over the Netherlands. And in fact, well, it's nearly 30,000 people, which is a small town in the Netherlands. Then if you go to the refugees in the municipalities who live there with a residence permit, often in the first 5 years a temporary permit, but it's difficult to say how many of them there are and how long will you call someone a refugee. I mean, how long after arrival we would still say there's a refugee. What I can tell you, if just about the numbers, if you look at Dr. Ansari's country of origin, Afghanistan, we've got 50,000 people from Afghanistan who live in the Netherlands currently. And if you look at the main countries of origin currently, it's Afghanistan, Eritrea, Ethiopia, Iraq, Iran, Somalia, and Syria. And you sum up the numbers, there's 350,000. Some of them, of course, have been living here for years already, and I don't know. Well, it would be better not to call them refugees anymore, but they do have this refugee background, which in fact also may turn into consequences of their background later on. Then we have the quotum refugees, whom are invited to the Netherlands through United Nations structures and so on. And there's approximately, I think, 500 every year. And then we have the undocumented migrants, the persons who have a negative decision on their asylum request. They may, well, they're not given reception anymore. So they won't stay in the Central Agency for the Reception of Asylum Seekers locations anymore. And some of them are living, well, in different kind of ways with family members or in church-run hostels and all kind of locations. And we don't know the numbers, in fact. Well, if you look at the health services, then in general, like I told you, in fact, everybody should have access to all kind of health service, all health services available for the undocumented migrant, with a bit more focus on emergency and well, crucial care. But in fact, also for them, it should be possible to receive healthcare. But we have some specific care services, and with respect to the people in asylum seeker centers, I want to start with the public health services, which is in fact the parallel of our GGD's. Well, they're a lot in the news, of course, with the corona pandemic, and infectious diseases control is a very important role. TB screening is often, yeah?
I have a question coming in about what it means, what you mean by quotum refugees.
Yes. Well, quotum refugees, that's people who fled their country of origin and then were living or are living in one of the camps that Stephen already mentioned. And then we have, with the International Organization for Migration, there's like agreements for every country that a certain number of people are invited to come here. And it's in general the most vulnerable people. And so when they arrive in the Netherlands, they come by plane, and they will immediately be allowed to go and live in a municipality. So a house will be, or a flat or whatever, will be arranged for them, which is appropriate for their conditions. So they don't go through the asylum procedure. Okay? Thank you for that question. And thank you for telling me about the question, because I try to focus. So Nienke will help me with your questions. Well, if we go back to the GGD services, we have the youth health services, youth health doctors and physicians, physicians and nurses, which is very important. So they offer the children, as soon as they arrive in the COA locations, they will be given, well, not immediately, but after a few weeks, they will be offered the like the consultatiebureau, like consultations to check for their growth, for well, mental health status of the children and their parents. Vaccinations will be provided. That's all what the GGD's do. They do the hygiene and safety inspections in the COA locations, and they provide health education and promotion information and sessions, and the infectious disease control. Well, currently, of course, with COVID is important in the centers as well, but it always is, because we've got scabies sometimes, and the TB screening is offered only to people from the countries of origin with a high incidence of tuberculosis. For people in asylum seekers, the family practice services are offered in a different way as well. They are contracted by the Central Agency for the Reception of Asylum Seekers. And well, it would be good to just remind this website and remind the way this is organized, because all information can be found here for asylum seekers and also for health professionals to find out how it is organized. And these family practitioners are ordinary family practitioners who have a practice for other people in the Netherlands in general, but they will, a few hours a week, provide specific services for asylum seekers. And there will be the nurse practitioners, a general nurse practitioner will work in these centers, and also nurse practitioners focusing on mental health, for example. If you look at other health services, curative services for asylum seekers, there is a different way of payment, because it's in fact not organized through our health insurance system. And so there is some specific things you should know or might need to know. But in general, just remind, all care can be provided, and in general, it will also be possible to go to a large part of the service providers. And very important, the medical interpreters are organized in a specific way for this group. Okay, it's not here, sorry. But there's a specific number, because the payment runs in a different way, and it's easy to call a medical interpreter through this service. If you look at the refugees in the municipality and the quotum refugees, who straight away go through the municipality, so they don't go through the, let's say, the months or years in the asylum seeker center, so they won't get used to the health system in the Netherlands. They will have regular care. Well, maybe you wonder why I use this image. Well, I use it because in my view, it's a system with cracks, in the sense that for them, if it's not clear how our system is organized, we can in theory say that everybody has full access. But how are you going to access care if you don't know where to go? And also if there is a language barrier, for example, maybe cultural barriers and so on. So in my view, we need to do a lot more to get good access and good care for these groups as well, although they will, as soon as they move into their house in the municipality or a flat in the municipality, they will just take a health insurance, and they will probably be helped by it by Vluchtelingenwerk Nederland, for example, to organize this. But that isn't all. And then on top of that, the own risk that we all need to pay may be a big barrier for these people. The undocumented migrants, well, I cannot explain everything about how care is organized. It's like told here, no, written here in the center, it's care that according to professional guidelines and standards is indicated, and that is effective and cost effective and patient centered, and that should be addressing the real needs of the patient. If you want to learn more about this, I can recommend you to read this report, because it's about access to care and gives a lot of recommendations also on how people will help these undocumented migrants, which is really something very important to do. I mean, they need a lot of help, and it takes a lot of time helping a Surinamese blind woman to get access. You really need to help. So you can read it over here. So that's the barriers. In fact, they've been addressed by the other speakers as well, and it's a puzzle for people. And we need something extra to offer to them. I just take the picture of my son Juma with Ibrahim, who at that time had arrived in the Netherlands with his Syrian parents, would really after a very, very hard time in Syria and a difficult travel trip to the Netherlands. He had arrived as a family reunification with his mother. His father had arrived earlier, and he didn't speak any Dutch yet. And then we had this jigsaw puzzle that we gave to him, and it turned out that Ibrahim, I think he was 7 at this when we took this photo, he had never done a jigsaw puzzle. And in the Netherlands, we can't imagine, and I see it as a parallel. I mean, in 1 minute, Juma had explained him to take the corners and to take the side pieces of the jigsaw puzzle, and then Ibrahim could do it himself. But you need to explain and help people to find their way. In times of Corona, but other times as well, we need to provide information in the languages of origin. Not all of them are able to read and write, especially, for example, this is from Eritrea. Not all Eritreans have been to school long enough to be able to read, so it must also be available in audio taping, and that is what Pharos is providing a lot. There's a lot of information in different languages, or easy languages for laaggeletterden, so it can help a lot if you get no access to Pharos resources. Then back to the language barriers, because of the limitations of time, I go through it rather quickly. We have a quality standard in the Netherlands, which was developed in 2014, when in fact the policy was of the Ministry of Health that people should pay for the interpreters themselves, the persons who don't speak Dutch. But then this quality standard already helped to improve the situation, because if you look at the WGBO, I don't know the word in English, and the quality laws in the Netherlands, so it's the professional and the quality laws, then it's the responsibility of care providers to provide good care, and also therefore it's their responsibility to ensure that they really inform the patient well, that they can get the informed consent, and that they discuss the treatments available. So the responsibility is clear, and what we are doing with our lobby is, because this quality standard was developed in a time where politically it was rather difficult and it's not up to date anymore. So we're really pleading for, at the highest level in the Ministry of Health, like at the highest level at Zorginstituut Nederland, we have together with a lot of professors, professional organizations, and a lot of experts, we've called on Zorginstituut Nederland, our healthcare institute to their quality board to put priority to a new quality standard with respect to working with patients with a language barrier. And we're really making good steps. So I think that we're going in the right direction. And well, just on this topic as well, I think just to give you quickly, I mean, it would be good to learn about it much more, and I hope it's in your training at medical school. But when a language barrier exists, you must work with an interpreter in case of complex health problems, medically or taboo, or any other complexity. Emotionally charged health problems you should also take the responsibility as a health professional and work with a medical interpreter, even if the person does bring a family member or a neighbor or a friend. And when they do bring these acquaintances, it may influence communication a lot. And the problem is that as a medical professional at that time, you don't know what is being said. And often the risk is that the family member or the friend will start communicating with you. And that whereas what you should aim at is having the conversation with the patient, between the patient and the patient and the health professional. And as the main message, never, never, ever work with an underage child as an interpreter. If someone brings an underage child as an interpreter, you just have to be very clear and don't work in that way. Well, I told you already,
Simone,
like, yeah.
I have a few questions coming in.
Yeah, what do we do? Because we can also maybe, are they really for clarification? Yeah.
Well, I think we're also running out of time. It's time to
Yeah.
start the panel. So I was wondering if you could answer these questions and
Okay.
then maybe round up your presentation.
Yeah. Okay.
So the first question is, what are the most common languages used by immigrants that medical practitioners have difficulty translating?
Oh, the most important languages. Well, I think that Berber from Morocco, of course, is spoken by many people, but they didn't come as refugees. They were labor migrants. And then Arabic. And then the difficulty with Arabic is that there's different forms of Arabic. So if you need an Arabic translator, interpreter, in fact, you should know whether it's a Syrian refugee, for example, needing an interpreter, because then you need to ask for Syrian Arabic. And then, well, we have Dari, Farsi, all the big groups. And this, well, the picture already is showing Tigrinya. And there's quite a number of Eritrean and Ethiopian refugees as well. And they, well, they speak Tigrinya. So there's many languages. And then we have a lot of migrants from Western countries as well. And even if someone does speak English rather well, it would be advisable in case of complex situations to call upon a professional interpreter as well. Is that a sufficient answer?
Yes, thank you so much. The second question is, when you mentioned that interpreters are not subsidized, does it mean that when the phone interpreter is used, the patient is ultimately charged for it?
No, the patient is not charged for it. What will happen is, well, in fact, already the university medical centers, just let me explain a bit more. University medical centers already have the possibility. They have a way of funding it themselves. Family practitioners have a way with achterstandsfondsen. And I can, well, the doctor may say, well, bring the interpreter yourself. But if the doctor calls or the nurse calls an interpreter, I cannot imagine that then the bill will go to the patient. I have never heard about that. Let's say it that way. And in fact, luckily there is a situation where it works well, and we have the financing issue, but we've also a different issue. It's that many health professionals are not aware of their responsibilities and or don't know how to work with a professional interpreter, or don't know how easy it is, because with the telephone and now with video conferences, it is not that difficult, especially not for the main languages, because you will have an interpreter on the line in a few minutes.
Okay, thank you so much. Maybe you could do a closing remark of your presentation, and then we move on to the panel.
Yeah. Well, I wanted to tell you this story because I started with a very sad story, and this can be told very shortly, because what happened is this is a delivery that took place last week in Leiden. And on the bottom left, you see Amy Welde-Selassie. She is an interpreter and a sleutelpersoon, so she's really a cultural mediator as well. And the gynecologist who did the delivery in the hospital asked Amy to write on the whiteboard the words for zuchten and persen in Tigrinya, and they together did the delivery, and it did such a lot of good to the delivering woman. And they really, I mean, the way Amy tells about it is just how much of joy and trust it creates if a medical doctor just learns 2 or 3 words, and then they really felt like doing the delivery together. And if I may, I think it's important to just share this last slide. It's all about offering an extra box if someone needs an extra box, whether it's someone from the Netherlands or from abroad. A rights-based approach to health requires that health policy and programs must prioritize the needs of those furthest behind, first towards greater equity, and that's WHO's statement, and that gets very close to human rights. And well, yeah, thank you, Elena, for translating. You're a good interpreter. And I just want to say one last, sorry for running out of time with the questions and too long a presentation, but you can really learn a lot by getting in touch with migrants. And during your studies now, if you find a way, for example, with the Welcome app, you can just have a drink together or make a video conference with a refugee or other migrant in the Netherlands, and you really can make a difference, and it will help you in your professional career. Be curious and listen and help to build trust as a closing message before we go to the discussion. Thank you very much.
Thank you so much, Simone. So what we're going to do right now is a panel discussion with Simone and Nasrat. If you guys have any questions for them, please put them in the chat.
Maybe it's good to read Judith's answer, because she works as a professional in a camp in an asylum seeker center, and she says we work with the interpreter by telephone. The Central Agency for the Reception of Asylum Seekers has organized a good contract with LiveWords, which is one of the big companies providing interpreter services. And then so there's no cost at all. It's not difficult at all. It's just through the the insurance number of the asylum seekers. And in a few minutes, you will have an interpreter on the line. And that's available for professionals working in the camp as well, for all other types of health services as well.
Thank you. I see a first question coming in. And the question is, why do you two think it's important for future doctors to learn about migration?
Yeah, I think migration is part of human lives. So human has been migrated from the beginning. It's not a new phenomenon. It's not something new in 21st century. If you look at the human history, if you look at the sapiens, it started with sapiens. So it continues. Now we are in 21st century. We need to know, we need to understand the human aspects of migration. And we need to understand the specific health problems of migrants. So it's, as I said earlier, it is based on evidence. This is not well understood, even in this world, even in 21st century. So if we do more researches, if we integrate it into the health education system, the medical education system, then opportunities for learning more will be evolved. So therefore, it is important for a medical doctor to understand not medical aspects of migration, but the health of migrants overall. It should be a holistic approach, not only the healthcare or medical care. It should be beyond. It should be as a part of public health. It should be integrated into the medical education programs.
Can I add to this question?
Please,
because I think it's a main question. I think that what we see is that the number of migrants, whether it's refugees or labor migrants or migrants who come for study to the Netherlands, has increased a lot. And also it's not a matter of the big cities alone anymore. If we look at non-Western migrants, traditionally they were more living in Amsterdam, Rotterdam, and The Hague, for example. But currently, with also the refugees being like, well, they are really, all municipalities in the Netherlands have a quota every year of refugees to provide housing to. So all professionals will have to do with migrants in their practice. And I just want to tell you one story of a gynecologist I work with a lot, and she works a lot with refugees and migrants in her practice. And she says it helps me, in fact, to structure my consultations, because thinking in a different way with a different culture, we really put on what is the core of medical care, and it helps her to communicate better with every patient, in fact. So she structures her consultations better than she did before. And I think we learn a lot, and that's a personal note to be added. It's diversity. It's such a richness. It helps you so much to know that you really have to think in different ways, and then, well, have to learn a lot from everyone. So I think it's really also kind of a game for everyone. And the only way to work well in healthcare with migrants is really if you get a bit of trust in your ability to work with them, listen well, and then we can achieve. Well, that's it for this question. There's a lot of other questions as well, I think. Can you?
Yes. Thank you guys so much for your answers. I have another question as well, and it's, how does the process of quota refugees work? How are they chosen? And how do they travel to the Netherlands?
It's specialists in IOM contracts and people in the camps, medical doctors, for example, and others, who will, together with a set of criteria, decide on who will be allowed to come here. And they will always travel by plane.
All right. Next question is, regarding health, what should be done in the new Inburgeringswet 2021? So that's integration law, because it seems that health is not taken into account and mental health not at all. What would you recommend to municipalities?
Nasra, do you want to answer?
Yeah, as I said earlier, it's a very important question. I think, as I said earlier, it's important to not segregate migration health from the health system in any country, in the like European countries or in Netherlands. If we talk about Netherlands here, when we talk about migration health, if it is only located in COA, it should, if it is separated, referral system will be complicated, and also healthcare for individuals will be different if it is not integrated into the health policy. For example, when you, personally, I have not experienced any receiving any healthcare from COA because I've never been in COA. But in the as a migrant, I received healthcare from the health system, current health system. Still, this is complicated because once it is the language barrier. One part is the language barrier, because when we speak English, like I used to speak English, and communication was a challenge. And the other thing is the cultural differences. So when we talk about integration, if the whole system is integrated, then it will be easier for all the doctors should be able to co-work with the people, with the other healthcare professionals in the COA. So they can understand each other, we can collaborate each other. That's why multidisciplinary approaches will be a useful approach or intervention to deal with the migration health problems. it will be much easier. Otherwise, if we, for example, in the Netherlands, if we segregate, the health problem of migration will persist. It will not be addressed in a systematic way. So it will be addressed in individual and separated, or can say in a different way or a current way. It doesn't work that way. So it's also recommended. It's not, it's also recommended by World Health Organization and many other institutions that integration of health immigrants is crucial to the national health policies, strategies, and plans, or maybe in action plans. So it's a bold recommendation by many health institutions in the world.
All right, thank you. Thank both of you. I have a question specifically for Nasrat, and that is a question by Leia. What are your thoughts on the importance of considering cultural differences in treating refugees, especially psychiatric treatments?
So I gave you, since my profession is gynecology, I can give you an example of gynecology, cultural differences in gynecology. Then we can move to psychology. First, the taboos. In psychiatry, for example, mental health is a taboo in Afghanistan. So if somebody has a mental health problem, he or she is called crazy person, crazy, absolutely, or mad. So that's why people are not sharing their personal information with a doctor or somebody else about their health problems. Regarding other cultural differences is the obstetric care. As a gynecologist, when I was treating patients in Afghanistan, it was challenging for me to treat women because the women did not want me to deliver her baby. They were so much hesitate to help her. I remember one of the ladies, one of the women in a hospital told me that I prefer to die before you touch me. Because she was delivering, she had a dystocia. So I had to help her to deliver her baby. And then I asked my assistants and midwives to help her. And I didn't touch her, but I was giving advice to the midwives to deliver a baby. So these kind of cultural differences should be considered. For example, if an Afghan woman is coming to the Netherlands and she is giving a birth, if there is no other option, if there is a male doctor during childbirth, it will be a challenge for the woman to receive a male doctor rather than a female doctor. So these kind of cultural differences should be considered.
All right, thank you. I have a question from Mate, and it is, do you also see problems in the medical care provision for migrants from within the EU who are not entitled to social benefits in Western European member states?
Shall I answer that question? I don't know so much about the social benefits, so I just want to link it to the healthcare access issues, if you agree. There's quite a lot of problems for them in light of access as well, and that is in the sense that there's a language barrier as well. They, for example, often the labor migrants in the Netherlands, for example, from Poland, often they don't have a family practitioner. So if they have a health problem, it's difficult to get access as well. And then we have cultural issues as well. So there's a lot of reasons for them why it may be difficult to get access. And I can give you one example of a Southeastern European migrant woman with HIV who didn't bring medication to the Netherlands. And then she, of course, had to find a way to get the drugs. And then because of the language barrier, she had to ask her employer to bring her to a family practitioner, whereas of course she didn't want the employer and the colleagues to know that she was HIV or that she is HIV positive. And then, but the family practitioner said, no, well, you have to find a way to bring an interpreter. So then this existed in this way, and then diplomacy as well said, well, we don't use interpreters, but she needed the medication. So there was step after step why access to healthcare was very difficult. I think there's quite a number of associations and volunteers that are helping with access to care for these kind of groups. And then, of course, what we read a lot in the news and hear a lot in the news these days in relation to Corona is that, well, there's also the social circumstances, people living in small housing, working conditions that are difficult and so on. So it's quite an adding up of difficult situations as well. On the other hand, in general, it's a young population. So, I mean, in that sense, the older population of all the labor migrants who are now running towards 60, 70, 80 years, and especially women haven't learned to speak Dutch, they as well have access to difficulties in accessing healthcare. So there's a lot of work to be done in this field.
Okay, thank you. We're going to do 2 more questions, and then unfortunately we're running out of time for the panel. So the second question is a smaller one. It's by Evangelia, and it says, victims of torture are an important vulnerable group amongst asylum seekers. However, they were not mentioned in any presentation. So I was wondering, what is your experience as doctors with this group of people in the asylum procedures? So victims of torture.
I just want to give a brief response. It is mentioned as a mental health problem. So, of course, it's a specialty. It's part of psychiatric patients. But if the patient is suffering from physical difficulties, then it should be treated differently. But most of the people who are suffering from torture are suffering from complication of mental health problems. So they should treat it differently, with care, with cautiously, I can say. So yes, we mentioned that psychological problem is a major prevalence among all the migrants.
Can I just add that in relation to the asylum procedure, I think that Viola Bax might better be able to address how torture can be taken into account and what doctors can do to document well the consequences of the torture and then contribute. Okay, Viola already says yes, so I stop. You had one other question, Nienke? Or?
Yes, the last question, unfortunately, we don't have time for any other questions, is, as an international, it's a question by Sarah, as an international medical student, what can I do to help? In addition to giving donations, are there any programs I can join to volunteer physically or to help interpreting the languages I know?
I gave one small recommendation: learn. As a student, besides what she is doing, that's great. She shows the passion for the health of people. This is great. I admire that. But besides that, she needs to learn more about migration and health, because it's a very complex phenomenon. It's not just easy to understand, but in order to understand and learn, she needs to study. That's why at the beginning I recommended that migration and health should be integrated into the medical education programs. Thank you.
Sarah, what I would like to add, and to the other students listening as well, the organizations that support undocumented migrants, and they exist in all bigger cities, they have very little funds, and there's a lot of voluntary work to be done in these organizations. And well, I would recommend you to learn a bit, and you can see it on the internet, what good medical interpreting is about, because then you could really be like an interpreter with the languages you speak. but there's more you can do. What I told about helping people to get access to the right healthcare, that would really be a very important contribution, and you would learn a lot on top of the learning that Nasrat is advising you to do as well. Thank you.
One more recommendation: when you talk to the immigrants, don't use medical terms. Use the lay language. Thank you.
Okay. Thank you guys so much for this super interesting panel. Before we move on to our next speaker, we're going to have a little break. We're running a little bit over time. I just want to repeat that we created a GoFund link for a really interesting organization. I put the link in our chat. Please consider donating if you enjoy this symposium. So right now we're going to do a little break for 5 minutes. So we'll be back, let's say 15:25. We're going to resume. See you guys at 15:25.